So a very good evening to everyone who's tuned in today for today's virtual program. It's a special day, World Heart Day. And what we thought was, on behalf of the RSSDI Diabetes and Women's Task Force, what other day to actually highlight the importance of women's health, especially cardiovascular health, rather than a day like this. So I welcome all of you for this small, crisp symposium that we have put together to discuss CVD in women with diabetes. This is an event that we planned with the blessings of our Honorable President, Sir, Dr. Vasant Kumar, Sir, who's always been very, very supportive of all our ideas and efforts. And we're so honored to have you with us, Sir. A very, very warm welcome from the task force for joining us. And to set the ball rolling, I think nobody would underestimate the power of awareness, prevention, and screening for diseases. Because once a person develops a disease, not only is it a burden in terms of finances, the physical burden, the mental burden, and the overall quality of life going down. When it comes to women with diabetes, we all know they are at a much higher risk for cardiovascular disease compared to their counterparts who do not have diabetes. We always think that probably breast cancer and cervical cancer and all those things are, the reproductive tract and all those issues are particular to women. But no, most of us will be surprised to know that cardiovascular disease still remains as one of the biggest causes of death when it comes to women. And if it comes to a woman with diabetes, her risk of CVD is much more, almost 3 to 7 times more than a woman without diabetes. Cardiovascular disease accounts for almost 15% of the global burden of heart ailments when it comes to diabetes in women. 3 in 5 women in India are at a high risk of cardiovascular disease. And imagine what age, as early as 35 years of age. So the young women are predisposed to a very high cardiovascular disease, especially when they have diabetes. So to discuss on various important aspects of CVD, we have our women diabetologists and endocrinologists who are going to share their knowledge, their insights, followed by a panel discussion. But before that, let me formally welcome our president, Dr. Vasant Kumar, Sir, for quick 2 words on this program and the burden of disease and why we put this together. And I must thank you, sir. You are the first one who actually thought of giving importance to women, having a special women and diabetes task force and guiding us through this entire project. So a very warm welcome and a heartfelt thanks from all of us.
Thank you, Dr. Shalini. It's wonderful to be with all of you this evening, where we are going to really have a very important program. And as you mentioned rightly, this is such an important thing, dealing with health issues of women. And I'm so happy that our task force members have done good work, and I expect them to continue this wonderful work while we are spreading awareness amongst all the women and also amongst our own community, our doctors. So obviously, when women are affected, the whole society is affected, and it affects even more than when the men are affected. I'm not trying to exaggerate. And it is so wonderful that today, on a very appropriate day, we have taken up this. And I really thank all the task force members. Let me mention their names. Shalini is here, Dr. Usha, Dr. Lily, Dr. Benny, and Dr. Mary and Anjali. So I congratulate all of you. And I'm so happy to be a part of this program, wherein we are very important and well-known speakers amongst you are going to deal with all the issues related to women's health, diabetes. And Dr. Shalini has already explained about the higher incidence of these complications and how the women are affected. And it's actually not an exaggeration to say that it is so important that perhaps we have not been giving this importance in all of our scientific meetings. I'm actually thankful to Dr. Usha also. I remember we started the program in November where she has very emphatically and gave us a very inspiring talk, and we all agreed to her. And I know it's a process, it goes on, but I'm sure it's another day to start such an important program to spread awareness. I wish you everyone a great, successful meeting today, and we look forward to listening to all our wonderful speakers. Thank you so much for giving me this chance, Dr. Shalini, and all of you. Thank you so much.
Thank you so much, sir. We will request you to stay with us for the program so that we can have your views in the panel discussion, a lot of discussions that we need to do with you at the helm of affairs. So friends, to kickstart, the first and foremost, we need to understand why when it comes to women with diabetes, heart disease becomes different. So to bring forth the insights into this, I welcome our first speaker, Dr. Usha Shriram, ma'am. I'm sure all of us know her very well. She does not really need an introduction. Somebody who's been championing the cause of women with diabetes, women's health, areas of special interest being the health of women, NCDs, gestational diabetes, preconception care, bone health, cancer and diabetes. We all know her as the founder of DIVAS, an NGO for prevention and care of diabetes and NCDs in girls and women, and president of the Indian Society of Bone and Mineral Research, and also an IDF Stream for Women and Diabetes Committee. So welcome, ma'am. The stage is yours.
Thank you so much, Shalini, and thank you, sir, Dr. Vasil Kumar, for actually a fantastic introduction and setting the stage for today's program. And I'm so thrilled to be with my colleagues, all of them who are working in the space of, I'm just sharing my slide, and just it's taking a second. It's coming up. Do you see it? Do you see my slides?
Yes, ma'am. You just need to put it on full screen mode.
Yeah, I've done it. Everything is taking a tad bit of a lag.
Yeah, there's a lag maybe.
Yeah, I've done it. So now, yeah, got it right. So the title of my talk is Diabetes and CV Risk in Women. How different is it? So today we are dealing with, I'm calling it sweethearts because it's diabetes and heart disease. And as you can see, this is the theme that has been given for World Heart Day of 2022. Very, very important that we look at heart disease with equity and realize the full potential, and also what the built environment and especially pollution can do. And for women, this becomes very relevant as I'll show you. So I'll discuss a little bit the scope of the problem, the drivers of diabetes, and why should we talk about heart disease in particular, and some unique gender perspective. So right off the bat, I want to show you there are some well-known traditional ASCVD risk factors and emerging non-traditional ASCVD risk factors. And you will see how when it comes to women, there are so many of these traditional and non-traditional risk factors. Today, we are going to talk about diabetes, but you can't talk about diabetes in isolation because it's often associated with obesity and overweight and dyslipidemia. So you can see they're all together. And you look on this side, there's all the gestational diabetes, hypertensive disorders of pregnancy, preterm delivery, autoimmune disease, and depression, and also things like miscarriages and polycystic ovary syndrome, infertility treatment. All of these are actually emerging non-traditional ASCVD risk factors. What really brought this whole thing into focus was across all continents except North America, we found that when women have diabetes, more women were dying than men, even though approximately equal number of men and women have diabetes across the world. In fact, men have a little bit more, because there are also more men in the world. So you can say it's about equal. But what we found was more women were dying dying everywhere. And so that raised a big red flag, like, why is this happening? And it's not a one-off thing. And if you look here between 1995, 2005, 2015, and particularly in middle and low income countries, this was becoming a challenge for women. So when you now look at this more carefully, you peel the layers and see coronary heart disease, stroke, vascular dementia, end-stage renal disease. Everything is much higher in women. And if you look at something like cancer, 27% more cancer than in women without diabetes, and in men it's about 19%. So the complications seem to be much higher in women. And I can also add complications like depression, which is 2 times more common. And there is a bidirectional relationship between depression and cardiovascular disease, and also diabetes control. We know that. There's also higher risk of things like fractures. And I'm just saying that all of these things, directly or indirectly, will be contributing to cardiovascular risk, stroke, and mortality. So in a study that was published in the British Medical Journal, you can see when age adjusted, the relative risk was still higher in women. And when they adjusted for multiple other variables, still it was much higher in women. So then the question comes, so why is this happening? Is it biology? Are women's, just their cardiovascular system or other metabolic system is different? Is it their life cycle? Is it social determinants of health? Is it behavior? So the short answer is all of the above. So let me just give you very quick examples of each one. So if you look here, there are both physiologic and pathologic sex differences. And if you look here under physiologic differences, there are so many things from energy expenditure to subcutaneous fat mass to liver fat, muscle mass, peripheral insulin sensitivity, and same with pathologic differences. So one thing that I want to quickly point out is in men, fasting glucose is higher, and in women, the 2-hour post glucose load or post OGTT is higher. So when we make the diagnosis, impaired glucose tolerance or pre-diabetes is more in women. I want you to keep this in mind because subsequently I'm going to show you the link between pre-diabetes and cardiovascular disease in women. So the social determinants of health that I mentioned, you look at here, whether it's individual characteristics and behavior, it could be gender, personal behavior, psychological coping skills, nutrition, lifestyle. It could be social and economic, big thing, education, income. We know how women are vulnerable and marginalized in these areas, and the physical environment as well. Now, I mentioned this earlier about air pollution, and we know that cooking fuels used by women adds to that and probably also increases the risk of cardiovascular disease. One other thing is the symptoms seem to be different in women. So traditionally, we think of cardiovascular, the angina as chest pain or discomfort, like a big weight that is placed on the chest. But when it comes to women, they usually have unusual upper body discomfort, shortness of breath, breaking out in a cold sweat, unusual or unexplained fatigue, lightheadedness or sudden dizziness, nausea, back pain. These are all things that women present with. And when they go to an emergency room with many of these complaints, it is usually not picked up as signs and symptoms of cardiovascular disease, but more as something to do with stress or fibromyalgia or something else. And to add to this, we all know that when people have, men and women have diabetes, they can also have silent MIs and very atypical presentations. So one other thing that is we all know is the tests that women and men undergo for diagnosing cardiovascular disease could have very different, physicians can take a very different approach to testing. And we also know that there can be abnormalities, baseline abnormalities, and then difficulty with diagnosing using some of the traditional tests in women. The third thing that happened was before 1993, in clinical trials, women were hardly included in that. Most testing done in clinical trials were conducted on men. So what happened was we did not know a lot about the behavior of cardiovascular disease or the behavior of diabetes in women, and how many of the medications we are now traditionally we are using for cardiovascular disease, how they performed in women. Fortunately, now the regulatory groups require a certain a good representation in both men and women in clinical trials. The Lancet actually has a Lancet Women and Cardiovascular Disease Commission, which, as I mentioned previously, the non-sex specific risk factors, which we can also call as non-traditional risk factors. But a couple of things that was not mentioned in the previous one, I want to bring it out here, are abuse and intimate partner violence, which we know now post-COVID has increased, poor health literacy, socioeconomic deprivation. These are all things that are very gender-specific risks, and they're also actually gender-specific risks for diabetes as well, which again, between diabetes and heart disease, when all of these risk factors are present, the risk is amplified that much more. Both in all diabetes, the risk is increased, and if you look at type 1 only, it is significantly increased. There are sex differences in endothelial function markers before conversion to pre-diabetes. Even before pre-diabetes, does the clock start ticking earlier among women? And sex disparities in control and treatment of modifiable risk factors. There are many studies looking at, are women given appropriate medication? Are they being given proper statins? Are they being followed up for risk factors? Now, coming to that, one other very, very important risk factor in women with diabetes is pre-diabetes. I know that we are going to have a detailed talk on this. Just want to point out the broken blue lines is pre-diabetes. You look at Chennai, Delhi, Karachi, everywhere, pretty high percentage of pre-diabetes in women. And if you look there between 20 to 24 or between 25 and 35, very young women having such a high percentage of pre-diabetes. And this wonderful paper from Nandita again shows that whether it is a city or a town or a village, the amount of pre-diabetes is significantly high in women. And what happens when you have pre-diabetes? Look at this. All the risk factors for coronary artery disease, dyslipidemia, visceral adiposity, increased waist circumference, gender obesity, hypertension, everything has gone up in the 10 years that between 2006 and 2016 when they studied. So on the one hand, you have pre-diabetes, and then the other hand, you have all the collection of CV risk factors. No wonder that women are at greater risk for cardiovascular disease. This is a very curious fact that I want to mention, that it takes about 2 years. There's a 2-year lag in women when diabetes is diagnosed. In that 2 years is when all a lot of the CV risk factors seem to accumulate. So I just want to show you. I showed you an earlier slide that said even before pre-diabetes, there is an susceptibility to CV risk. So people with normal glucose metabolism, they increase weight. The further increase in weight, then there is abdominal visceral fat. And then women have a stronger association of abdominal visceral fat with insulin resistance than men. And women possibly have more adverse cardiometabolic consequences of abdominal fat than men. Then they go on to developing type 2 diabetes, and then they have a higher relative risk on diabetes associated CVD, and then you can see the CVD. So this progress, and I like to say that our mantra should be no progress is good progress, meaning we don't want our women who have normal glucose tolerance to go to pre-diabetes, those who have pre-diabetes to go to diabetes, from diabetes to having complications like cardiovascular disease, and of course from cardiovascular disease, we don't want women to lose their lives. So we need to act real early while they're still normal. That's the moral of the story. One other thing is women have a life cycle that's entirely unique, whether it is pregnancy, menopause, all of those things, unique, our unique life cycle. And one of the things that we all know about is gestational diabetes. We always knew that gestational diabetes increases the risk of future type 2 diabetes significantly within 5 to 10 years of the index pregnancy. As much as 50 to 70% of the women can develop some form of dysglycemia, either pre-diabetes or diabetes. GDM tends to recur in subsequent pregnancies. Children born to mothers with GDM are at greater risk for future type 2 diabetes, obesity, visceral fat. But then we did not know for a long time that GDM itself increases the risk of cardiovascular disease in women. Just GDM, not women with GDM who went on to develop diabetes, but just on the basis of GDM, increased risk of cardiovascular disease. So another aspect of our unique life cycle is every time a woman gets pregnant, there's some weight gain. Gestational weight gain is retained from first pregnancy to second pregnancy. So later on in life, increased BMI, increased fat mass, increased visceral fat, so increased risk for cardiovascular disease. We cannot forget to talk about obesity in women. Lots of reasons. One of the things actually is that women have special challenges, and which is why we talked about the social determinants of health and cultural norms. And this is a woman who is not allowed to go anywhere, and just out of depression, she's probably eating and gaining weight. And obesity indicators, and in a fantastic study from Vellore, they actually showed that the great psychosocial impact of obesity, and we know what depression has an effect on cardiovascular disease, and women being more obese than men, and you can see how one thing can lead to another, increased risk of cardiovascular disease. I'm coming to the end of my talk. I just want to say that cardiovascular disease in women in general, I'm not talking about diabetes alone, in general, is understudied, underrecognized, undertreated, and women are underrepresented in clinical trials. Some of this is changing, but I think we have a lot of work to do, and big change needs to happen. And one of the things that we feel is if there is gender-specific guidelines in diabetes care, probably will raise more, raise the alarm, raise the flag important things, and probably pay attention to non-traditional risk factors and treat women. Full model has been the Go Red for Women campaign in the United States. In fact, this is one of the campaigns that motivated me and continues to motivate me to pay attention to women and diabetes, and women and diabetes-related complications, gestational diabetes. And you can just see what a dramatic difference. It was, it was around 2000 when the Go Red was initiated, and in 2003 when it actually, became something that people rolled out pretty much throughout the US, and the dramatic drop in cardiovascular mortality trends, both for men and women, but more so dramatically for women. So I'm going to end my slide with end my talk with this important slide, which is drivers of diabetes in women. If we want to decrease cardiovascular risk, first we need to prevent diabetes. And to prevent diabetes, there are so many modifiable risk factors. Of course, urbanization and globalization are here to stay. But obesity, sedentary lifestyle are modifiable. We can work on preventing gestational diabetes, especially in women who have had GDM in subsequent pregnancies. We can work hard on PCOS and decrease risk of diabetes and CV risk, and then lower, help women to lower stress and lift women out of poverty, which is going to help them in a great way. Thank you so much.
Thank you so much, Dr. Usha, ma'am, for that very enlightening talk on how women with diabetes are different, how they have so many differences. So, when we talk of men and women being equal, I think we need to understand, yes, there are similarities, but then there are differences, and we need to be very sensitive to those differences. So we'll have the discussion, ma'am. We'll request you to stay for the panel discussion towards the end. With that, we move on to our second topic. Dr. Usha in her slides talked about the 2-year gap. Women tend to develop diabetes. Maybe there's a gap between men and women of almost 2 years. So to take this forward, whether that time when the woman is still pre-diabetic, what happens? Is she still at a high cardiovascular risk? And to shed light on this, we have my colleague with the Diabetes and Women's Task Force, Dr. Lily Rodriguez, who's going to shed light on how pre-diabetes also is a state where the woman's cardiovascular disease risk is very high. All of us know her. She's president-elect for Telangana chapter of the RSSDI. All of us know her, practicing in Hyderabad. So, ma'am, welcome. The stage is yours.
Thank you. Thank you for that wonderful introduction, Shalini. It is a great pleasure to be here. And on this World Heart Day, what else? The topic that is being given to me is pre-diabetes, metabolic syndrome, and cardiovascular risk. And I think there cannot be a more apt topic than this. I would be going through the definition of pre-diabetes, risk complications, and then metabolic syndrome a little bit on, again, definition, diagnosis, risk factors, complications, and prevention, and finally conclude the talk. Coming to pre-diabetes, pre-diabetes is defined as plasma glucose levels that are elevated above normal range and below the threshold for diabetes. We all know the levels. The pre-diabetes state is related to increased insulin resistance rather than decreased insulin secretion. So during the pre-diabetes stage, it is more of an insulin resistance than the decreasing. So early diagnosis, therefore, identifies persons at risk and prevents the progression to type 2 diabetes and cardiovascular disease. So as according to the American Diabetes Association, they have laid down some guidelines for screening the pre-diabetes women as well as men. The fasting blood sugar test or oral glucose tolerance test and HbA1c. Who should be screened? The guidelines say that everyone above the age of 35 and even before the age of 35 if the risk factors are indicated. And then repeat screening every 3 years if the test results were normal at the beginning. Then, but more frequently it should be done if the risk factors are more. Now, pre-diabetes to diabetes, that's what we are worried about, because that is what we need to tackle. So 1 out of every 2 people with pre-diabetes will develop diabetes within 5 to 10 years of being diagnosed with pre-diabetes. This may be much faster as we see in our country. This is, this is what we see in the US perhaps and many other Western countries. But South Asians, particularly Indians, have seen that pre-diabetes pushes us to diabetes even much earlier than 2 years or even 1 year. So if you have pre-diabetes, you should be screened every year for diabetes, and then find out the risks for pre-diabetes. So being overweight as Dr. Usha Sriram has already set the stage for this topic, obesity is one of the most important risk factor. Family history of diabetes over the 35 years of age as of now, high blood pressure, high cholesterol, not being active enough, and being an Indian, diabetes during pregnancy, and polycystic ovarian syndrome. So can we reduce our risks? The risks of pre-diabetes can be reduced by even a small amount of weight loss. It is said from the studies that even 4% of your basic weight loss gives us almost 30% of reduction of chances of developing pre-diabetes. This can be done by healthy eating and by being active. If you decrease how much food you eat by 250 calories a day, perhaps you can lose half a pound of weight per week. One must do it diligently. So there are a few steps to help you eat less. Write down everything you eat, keep a journal, food diary, or web app to count the calories. Use smaller plates and bowls, as you see here. Then when eating out, going to a hotel, always ask for a box or a pack home. So at the start of the meal, put half of the meal in the box for the next day. So don't watch TV, talk on the phone, or browse the web while eating. These are a few tips to reduce the risks. Now, what is healthy eating? While eating less is very important, eating right also is more important than to reduce the risk of pre-diabetes. Eat more fruits and veggies, whole grains, low-fat milk and cheese, chicken, fish, and lean meats. Eat less of saturated foods such as butter and foods, fried foods, salty foods, stored foods, and then simple sugars found in the junk food and sodas and desserts. So we all know this. It's just a recap of what we know. Then the plate method, we all are advocating in our clinics to all our patients. So vegetables, half the plate, proteins, and then carbs. So much for the pre-diabetes. Now coming to the metabolic syndrome. Metabolic syndrome is a atherogenic metabolic triad. That includes hyperinsulinemia, small LDL particles, and elevated ApoB, which is seen with the abdominal obesity and metabolic complications leading to more than 20% coronary heart disease risk. Now, metabolic syndrome has been referred to as a clustering of cardiovascular factors, which I just mentioned, including abdominal obesity, atherogenic dyslipidemia, increased blood pressure, insulin resistance, and pro-inflammatory state, and it is a pro-thrombotic state as well. So it has become one of the leading clinical issues discussed by physicians and the media as well of late, leading to increased public awareness for sure, but our responsibility is to bring a potential change and improve the catastrophic multiplex risk factor for cardiovascular disease. Now, how do we diagnose a metabolic syndrome? And this is a NCEP criteria, maybe quite old, but still stands good. Diagnosis requires 3 or more of the following features. Waist more than 40 inches in males and 35 in females, and maybe 32 for Indian females. Then triglycerides more than 150, HDL less than 40 in males and less than 50 in females, or even after treatment. Or if a person is on treatment for low HDL, then systolic blood pressure more than 130 and diastolic more than 85. Plasma fasting glucose is more than 100 milligrams. So these are one of the 3 out of the 5 features positive is good enough to diagnose a metabolic syndrome. Now coming to the important risk factors of metabolic syndrome, that is apple-shaped midsection, extra weight around the middle of the body. If one starts maybe right from childhood, I will be talking about that a little later, then we have insulin resistance. Body is unable to utilize the insulin effectively to control the blood sugars. And the other risk factors, which are non-modifiable, perhaps increase incidence as age increases, race, greater risk in Hispanics and Asians and Indians, history of diabetes, family history of type 2 diabetes mellitus, and then history of other medical conditions like high blood pressure, polycystic ovarian syndrome, and pre-existing cardiovascular disease. Now, coming to the complications of metabolic syndrome, we all know that pushes them into insulin resistance, which can lead to increased blood sugar and values resulting in type 2 diabetes. So before the type 2 diabetes, if screened properly, the individuals can be diagnosed during the pre-diabetic stage, and then that can be prevented. The type 2 diabetes can be delayed or prevented. Then the other complication, the most important complication is cardiovascular disease. That is plaque building up in the arteries, and high blood pressure can cause heart attacks and strokes even in the pre-diabetes stage. Now, a word about insulin resistance syndrome, which was otherwise known as the metabolic syndrome. For a long time, we spoke about insulin resistance syndrome. And then, these are all the factors: sedentary lifestyle, genetics, dyslipidemia that we already said, hypertension, hyperglycemia, hyperinsulinemia, and altered fibrinolysis, inflammation, endothelial dysfunction, aging, and obesity. All these give rise to insulin resistance. Now, coming to insulin resistance syndrome in children, why I put up this slide in this talk is because I think we need to tackle the pre-diabetes right from childhood and adolescent girls and women. And if we do not do that, we have an exploding problem of type 2 diabetes. The major cause of insulin resistance in childhood is a typical lipid partitioning pattern characterized by increased deposition of lipids within the insulin responsive tissues like liver, skeletal muscle, and within the viscera. The lipid deposition pattern is also associated with infiltration of intra-abdominal tissues with cells of immune system. So there is a low-grade inflammation, and then typically observed in insulin-resistant obese children and adolescents. So careful history and physical examination along with the basic laboratory workup provides clues in regards to the risk stratification in these obese children. So this is taken from the Journal of Pediatric Endocrinology. So this is what happens: excess energy intake, sedentary lifestyle, increased body fat, lipid partitioning, and then intra-abdominal body fat, intrahepatic fat, and intramuscular fat. And there is insulin resistance, then subclinical inflammation with increased waist circumference, acanthosis nigricans, which is a clinical sign of insulin resistance. Then triglycerides, elevation of triglycerides, fasting to our glucose may go up, blood pressure may go up, and then inflammatory markers which can be identified like elevated CRP, IL-6, and ALT, and then HDL cholesterol going lower. So can we improve the metabolic syndrome? Yes. Again, boiling down to the lifestyle, eating healthy, food with low cholesterol, low sodium, and DASH diet, increasing physical activity, which is 150 to 300 minutes per week or more if you can. Then lose weight, aim for at least 7% of weight reduction, and stop smoking. And a few words about the healthy heart nutrition. Limit the daily cholesterol intake to less than 200 milligrams. Yellow of the eggs to be avoided. Avoid foods with high saturated and trans fats like butter, whole milk, fried food, pastries, cookies, and desserts. Then include healthier mono and polyunsaturated fats like almonds, walnuts, peanut butter, sunflower seeds, and ground flax seeds. So choose fat-free dairy products like skim milk, fat-free and light yogurt. So one word about sodium recommendations. For men, the estimated intake is about much more than this probably in India. We all tend to eat much more salt than the Westerners. So women, the estimated salt intake that is seen is 3,300 milligrams elemental sodium. But the recommendation is from 1,500 to 2,000 milligrams, depending on the age of the woman. And then that, just to know, 1 teaspoon of salt equals approximately 2,300 milligrams of elemental sodium. Now, coming to the final conclusion, that physicians do not record a diagnosis of pre-diabetes is very intriguing and a matter of concern. Pre-diabetes is an important recognizable cardiometabolic risk factor that needs to be addressed if one were to prevent or delay the twin trouble of diabetes and cardiovascular disease in the new millennium. It is recommended that one should systematically screen for pre-diabetes and offer positive screeners effective interventions to prevent or delay the onset of diabetes and macrovascular disease. The preferred clinical approach to cardiovascular prevention is to treat all the metabolic risk factors. For both pre-diabetes and metabolic syndrome, the approach is lifestyle intervention, especially weight reduction and physical activity. When drug therapy is contemplated for metabolic syndrome or pre-diabetes, the primary consideration is prevention of cardiovascular disease. The major targets are elevations of cholesterol and blood pressure. Evaluate obese children and treat the metabolic syndrome early and reverse the risk, because children, it can be reversed. In the adults, it may not be possible always, but in children, it is studies have shown that metabolic risk factors can be reversed if the interventions are proper. CV risk assessment should be done in every clinic for everyone who is pre-diabetic and who has metabolic syndrome. So in adults, pre-diabetes is associated with risk for cardiovascular disease like myocardial infarction and strokes. Concerns have been raised about the potential effect of pre-diabetes on morbidity in adolescents as well. High percentage of children and adolescents with pre-diabetes will convert to normal glucose tolerance over time if interventions are undertaken. And then interventions in adolescents with pre-diabetes, lifestyle change, focusing on development of healthier dietary and activity habits is the mainstay of treatment and a future hope for all of us. I thank each and everyone for patient listening. Thank you very much.
Thank you so much, Lily ma'am. I think this puts things in perspective when we're talking about the awareness for women's health, why we need to be very, very aware. And the whole idea of managing, screening, prevention has to start not only when she's turned diabetic, because we know women with diabetes are at a high CVD risk, but even when she is in this stage where a lot of things can be done to reverse the trajectory of disease. So right at the stage of when she's developed metabolic syndrome or she's pre-diabetic, I think that is where the CVD risk starts. And this is where we need to intervene. So thank you so much, ma'am, for that very enlightening talk. And we'll request you to stay back for the panel discussion. So with this, we now move on to another eminent speaker, a very senior and respected senior colleague of ours, Dr. Benny Negalur, ma'am. All of us know her well, an eminent academician. She's the founder president of WODCON, organizing the Women and Diabetes Conference for the last 5 years, practicing at Jupiter Hospital, Thane, and director for Dr. Negalur's Diabetes and Thyroid Specialties Center, and so many other feathers in her cap. So Benny ma'am is going to tell us how, when we're talking of CVD in women, nowadays we talk of the hidden elephant in room, which is no more hidden because we've already been talking about it, the heart failure in women. So when it comes to, differences between how men and women behave differently in terms of CVD, heart failure is again something where we have very clear differences between men and women. So to shed more light on this, I welcome Benny ma'am, and she will be talking on how pathophysiology of heart failure and heart failure per se is different in men and women.
Thank you so
Welcome,
much,
ma'am.
Shalini. Yeah, thank you so much, Shalini. And it's a real pleasure to be here and part of the Women and Diabetes Task Force. And I thank you for giving me this topic, because I went into the detail of the pathophysiology, and I realized that once you understand the pathophysiology, things are very simple in the management, because heart failure is frequent, it is forgotten, and often fatal complication of diabetes. This was told by David Bell in Diabetes Care 2003. I'll just enlarge my screen. Yeah. So you see that heart failure is a very complex disorder. 16% of the population has diabetes, and 32% of patients with CAD have type 2 diabetes. 12% to 45% of patients with heart failure have type 2 diabetes, and about 40% of patients with heart failure have CKD, and 20 to 44% of patients with type 2 diabetes have CKD, and 76% of patients with CVD and type 2 diabetes have CKD. And if you see those 4 circles there, all of them are interconnected. We should not feel that heart failure is a separate entity by itself. It is intimately connected with kidney disease. It is intimately connected with type 2 diabetes and also with atherosclerotic cardiovascular disease. And if you go back to the physiology of heart failure, to start from the beginning, the cardiomyocytes, there are about 2 to 3 billion cardiac muscle cells. And all these electrically synchronize to contract and generate a pressure. And it is this pressure that is maintained during the cardiac cycle and gives rise to a cardiac output and also brings the venous return back. So we have 74 beats per minute with a cardiac output of 52 ml per beat, and about 3 to 9 liters of cardiac output in 1 minute. But then this can be up titrated to adjust for a myriad of physiologies. For example, running, shivering, overheating, stress, sleep, infection, bleeding. This system can scale up to 20 liters per minute. I mean, just to hear this also is just see the amount of rise of the cardiac output that happens in certain situations. And this pressure and output is required, especially the pulse pressure, which is the difference between the systolic and the diastolic pressure, to maintain the perfusion of the organs. And if you look on the right-hand side, you will see that 27% goes to the liver, 20% goes to the kidney and the skeletal muscle, 20% each, 14% goes to the brain, and the rest in a small quantity are distributed to the other tissues, showing that the liver actually is the mainstay of all metabolic issues, and it has the highest blood supply. I thought, compared to the liver, even the brain would get, but you look at this, the brain is just 14%, but the kidneys and muscles are much more than that. So heart failure is a loss of this function, and traditionally we know the symptoms as shortness of breath, as orthopnea, where the person has to sit down to get relief, as edema feet, raised JVP, and a pulmonary congestion seen on the X-ray and also clinically. And you will see also the enlarged cardiac chambers here on echocardiography. And in other words, the left side of the heart, the pressure is increased, which drives the blood to the pulmonary system, and then the right side pressures also increase to give rise to the classical signs and symptoms of heart failure. So to define heart failure, it is a clinical syndrome with symptoms and signs caused by structural or functional cardiac abnormality. But this has to be corroborated by at least one of the following: either elevated natriuretic peptide levels, or an objective evidence of cardiogenic, pulmonary, or systemic congestion. And to look at the structural or functional cardiac abnormalities, we have to rely on the echocardiogram. If the LVEF is less than 50, or the E/E, that is the velocity during the early diastole and the end diastole, the ratio is more than 15, or that there's a chamber enlargement, or there's a moderate LVH, or there's a moderate valve dysfunction, along with signs and symptoms of heart failure, and with elevation of any of the natriuretic peptides like BNP, which is more than 100, and NT-proBNP, which is more than 125, more than 100 and more than 300 requires hospitalization of the patient, or there is objective evidence of pulmonary and systemic congestion by an echocardiogram, an X-ray chest, or a right heart congestion or pulmonary artery congestion at rest or during exercise. Then you have made a definition of heart failure. The salient points are that heart failure is 2 to 5 times more common in diabetic patients, and it increases the mortality at least 3 times compared to the other condition. And we know of the stages of heart failure, so I won't go into the detail. These are all structural heart disease with symptoms, without signs and symptoms. See, stage 3 is heart change in prior current symptoms, and stage 4 is refractory heart failure. But now you see the classification has changed, and most of the trials that are done depend on the HEF-REF and the HEF-PEF. Now, what is this terminology? HEF, the heart failure with reduced ejection fraction, is HEF-REF, and HEF-PEF is heart failure with moderately reduced ejection fraction, or heart failure with a preserved ejection fraction. So we are now talking of HEF-REF and HEF-PEF, both in men and women. Again, to go to the basics of what is HEF-REF, if the LVEF is less than 40%, it is a heart failure with reduced ejection fraction. If the LVEF is between 41 and 49%, it is a heart failure with mildly reduced ejection fraction. And if the LVEF is more than 50%, then it is a HEF-PEF, or a heart failure with preserved ejection fraction. Sometimes you know that heart failure can improve a little bit, or it could be error of the person. So that's why we need to have a heart failure with a baseline LVEF, which is less than 40, which is already a reduced ejection fraction, but a greater than 10-point increase from baseline LVEF and a second measurement of LVEF more than 40, then you will say that this is a heart failure with improved ejection fraction. These are the new terminologies, and that's why these 4 terminologies are used in most of the trials. Now, what about diabetes and heart failure phenotypes? So what is HEF-PEF? In HEF-PEF, really speaking, the cardiomyocytes are not affected intrinsically. So you don't have coronary heart disease, you don't have heart attacks, but you see there is secondary effects of the systemic circulation and oxidative stress coming from outside, which is generated in the cardiomyocytes. So obesity-induced systemic inflammation and advanced glycated end product deposition will reduce the nitric oxide and produce hypertrophy of the cardiomyocytes. At the same time, the fibroblasts will produce an interstitial reactive fibrosis. So a HEF-PEF is basically a hypertrophy of the cardiomyocytes secondary to issues that lie outside the cardiac muscle. Whereas a HEF-REF, or a reduced ejection fraction, is basically due to cell death. For example, the patient could have had a myocardial infarct or could have had recurrent attacks of angina, and that will produce death of the cardiomyocytes, and this can produce a reduced ejection fraction. But the fibroblasts that are stimulated in HEF-REF will produce replacement fibrosis, which is too much of a fibrosis, and it doesn't allow the cardiac muscle to stretch in that area. Having understood this, let's see what is the relation of diabetes and heart failure. It's shown on the right-hand side that compared to non-diabetic individuals, diabetic patients have a higher prevalence of heart failure. And if you look on the left-hand side, you will see that the glucose levels, which predict hospitalization, are high in patients of normal low sugars, then higher in normal high sugars, and then impaired fasting glucose and impaired glucose tolerance, new diabetes, and finally diabetes. So in other words, glucose intolerance at any time, when it is normal low or normal high, also in the pre-diabetic stage, and in the new diabetes, new onset of diabetes, and in frank diabetes, you see it predicts the hospitalization for congestive heart failure. And for every 1% increase in the A1C, there is an 8% increase in heart failure. Now, there is an interplay between metabolic disturbances and the hearts. I think the problem is the obesity, increase in free fatty acids, which actually stimulate the sympathetic nervous system. And this system, which is chronically upregulated or stimulated, gives rise finally to hypertension. The increase in free fatty acids also produces endothelial dysfunction and a vasoconstriction, causes increased resorption of sodium, and increases the blood pressure. And we know that hypertension is a high risk for congestive heart failure. At the same time, they also inhibit, we know insulin action is inhibited, which can cause insulin resistance and hyperglycemia, and that is an increased risk for type 2 diabetes and also risk for heart progression. And the free fatty acids that are stored in the extra fat tissue, that is the ectopic fat, and also fat around the heart, also is a high risk for heart failure. So it boils down to fat and obesity and all the markers, inflammatory markers of obesity and the oxidant stress that are the drivers for heart failure. In addition, you see in diabetes, there are other comorbidities, diabetic nephropathy, coronary microvascular dysfunction, coronary artery disease, hypertension, and diabetic cardiomyopathy, which actually drives and progresses heart failure. And in type 1 diabetes, myocardial injury is seen secondary to an overactive adaptive immune response to alpha myosin. And this increases the expansion and persistent activation of pro-inflammatory alpha-myosin reactive CD4 T cells. In other words, the autoantibodies which are detrimental to the heart muscle, the cardiac autoantibodies are increased, and they cause damage to the cardiac muscle. Also, there is an elevated hsCRP levels, which suggests that there is markedly increased inflammation in type 1 diabetes. Now, this is the phenotype that you see. And what are the determinants? You see that cardiac function can decrease and progress. Cardiac function progresses all through the age of diabetes because you have other drivers of the metabolic syndrome and complications, and genes and sex. Female sex, so women, have more heart failure compared to the men. So they are genetically predisposed, and there are other drivers as well. Hypertension, the more it is uncontrolled, the more you will see that the cardiac chambers increase in size and propagate heart failure. The more coronary artery disease, the more the heart failure, and more the complications, coronary microvascular dysfunction and diabetic nephropathy, and diabetic cardiomyopathy, which is a microvascular complication of diabetes in women especially, predisposes them to the progress of heart failure. And it is the heart failure that begets heart failure. So you see the patient has heart failure. Even if they don't have diabetes, heart failure itself can produce pancreatic dysfunction. It can increase the neurohumoral overactivity, decrease the insulin delivery, produce insulin resistance and inflammation, and produce impaired fasting glucose and impaired glucose tolerance, an entity known as cardiogenic diabetes. And once the person has a cardiogenic diabetes, then it will produce more imbalances of the free fatty acid metabolism and decrease the cardiomyocyte energy level and the microvascular dysfunction and damage the cardiac muscle further, progressing to heart failure. And this is a vicious cycle. So heart failure begets heart failure. Now, heart failure and diabetes are both characterized by a neurohumoral activation. As you can see, diabetes by itself, heart failure, increases upregulates the sympathetic nervous activity, increases the renin-angiotensin system, increases aldosterone, and increases neprilysin. Neprilysin is an enzyme that plays a big role in the breakdown of the natriuretic factors. And now we know, now since I've told you the 4 pathways, we know that the treatment of heart failure now in reduced ejection fraction is attending to each one. So we have 4 pillars: decreasing sympathetic activity, RAS blockade, you have mineralocorticoid inhibitors, and you also have neprilysin inhibitors. And these 4 pathways can increase and progress heart failure to a great extent. You also see that both heart failure and diabetes are both characterized by increase in pressures and increase in the pressures and remodeling in critical organs. Wherever the heart, if anything happens to the heart, the same thing happens to the kidney. And we know of diabetes, and the new guidelines always keeps the cardio-renal axis as very prominently in the management of type 2 diabetes, because where the heart goes, the kidney also goes. And you see the treatment of the increasing pressures in the heart failure, increasing the chambers, will also increase the pressure in the renal glomerulus and have the same effect as heart failure in the heart and kidney failure in the kidneys. So the treatment is the same for both. You see, you give ACE inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists, and neprilysin inhibitors, which is both for decreasing the pressures in the heart and in the kidney. Activation of the sodium hydrogen exchanger is one of the basic pathophysiological mechanisms why heart failure is produced and why it is propagated. So you have NHE1 in the heart and you have NH3 in the kidneys. And what does this sodium hydrogen exchanger do? It is upregulated in heart failure. Normally, this is required to throw the sodium outside the cell and to bring the potassium inside and to also put this hydrogen outside the cell. Basically, the work of the kidney and the body is to throw the hydrogen out and to keep the sodium outside of the cell. But when these 2 enzymes are upregulated, one in the heart and the kidney, you see that the total imbalance of the electrolyte, there is a sodium retention in the glomerular hypofiltrate, and there is a sodium retention also in the cardiomyocyte, which produces cardiac injury and increase in the cardiac wall stress. Just to diverge, insulin, pioglitazone, and saxagliptin also upregulate the sodium hydrogen exchanger. And that is why you see edema in all these 3 conditions. You see edema, insulin edema, you see edema and heart failure in pioglitazone, and you also see heart failure in saxagliptin. So all that knowledge of saying that pioglitazone edema is because of retention of sodium is basically because it finally acts on the sodium hydrogen exchanger. And the upregulation of the NHE1 and the NH3 also has its effect on the microvascular complications. It can increase or progress retinopathy. It can increase or progressed neuropathy as well, besides producing cardiomyopathy and renal failure and end-stage renal disease. Now, just to bring to our notice, SGLT2 transporters are not present in the heart. Then why do we give SGLT2 inhibitors? How does it benefit the heart? It is because the NHE1 in the heart has a docking site for SGLT2, and therefore it can regulate the activity of NHE. Thereby, it can correct the electrolyte balance, decrease the sodium, decrease the calcium in the cardiomyocyte and also in the mitochondria. So the mitochondria efficiency increases and the cell viability increases. And that's how the SGLT2 inhibitors are beneficial in heart failure. Another thing about heart failure is the metabolic inflexibility that happens in diabetes. You will see that the normal fuel required for the heart is glucose during the day and maybe fatty acids in the intraprandial state. And also the branched chain amino acids and ketones can also be a fuel for the heart. But what happens in diabetes? In diabetes, there is so much glucose, but it cannot reach the cardiomyocytes. There's an insulin resistance. And therefore, you're getting the wrong fuel to the heart. You're getting the fatty acids in excess, you're getting the ketones and the branch chain amino acids to a small degree. And that actually, the wrong fuel actually perpetuates and is one of the mechanisms that is a driver for further heart failure. Once you give an SGLT2 inhibitor, you see this fuel is corrected. The glucose is driven inside. The fatty acid is also taken by the heart in the intraprandial state. And the heart uses the ketones and the branch chain amino acids. And that increases the efficiency of heart failure with the SGLT2 inhibitors. Another, as I told you already, so goes the heart, so goes the kidney. The kidney works in tandem with the heart. If the heart is failed, because there has to be a balance between the RAS, sympathetic nervous system, the NP system, and the RAS system. So if there is a good balance between two, both the heart is happy and the kidney is also happy. If there is an imbalance in this, then there's a driving force to also produce kidney failure. And if there's a kidney failure, there's a driving force to also increase heart failure. And we know that we get heart failure in kidney disease. And because of low perfusion and other inflammatory markers, there is also kidney failure in heart disease. Now, how do the type 2 diabetes, obesity, accumulation of glucose and lipid intermediates in the cytosol are detrimental to the cardiac muscle? They are signals which are triggered by energy surplus. Again, coming back to obesity and nutrient excess. Anytime there's a nutrient excess in the cells, and now we are talking of cardiomyocytes, there are two systems that are upregulated. One is the AKT system, and second is the mTOR system. And when this system is upregulated, there's a suppression of autophagy. Autophagy means clearing up all the kachra from the cardiomyocytes. Like, for example, after cooking, we keep the kitchen clean. That is autophagy of the kitchen. So autophagy is required to keep the viability and the efficiency of the cells. So when these are stimulated, there is suppression of this autophagy, there's increased oxidative stress, there's organellar dysfunction and activation of the pro-inflammatory pathways. And this drives the development of cardiomyopathy. What happens when you take an SGLT2 inhibitor? When you take an SGLT2 inhibitor, these signals are activated. It produces kind of a nutrient deprivation in the cardiomyocytes. And so the SIRT, which is the gene for longevity, PGC1 alpha and FGS21, all of them do the opposite. The mistakes done by the upregulation of the other pathway. And therefore, they can help in the treatment of heart failure. Again, to tell you, because this is very important, it upregulates SIRT1 and the AMP kinase pathway, activates autophagy, relieves oxidative stress and organellar dysfunction and inflammation, and thereby slows the development of cardiomyopathy and nephropathy. So upregulation of SIRT1 can reduce uric acid synthesis, can increase ketogenesis, and increase hematocrit. All these signals are signals of nutrient deprivation, which are essential for the cardiac muscle. Any stretching of the cardiac muscle can give rise to atrial fibrillation. Once atrial fibrillation occurs, it causes more heart failure, and heart failure causes more atrial fibrillation. So this is again another cycle, because the heart is trying to remodel after increase in the oxidant stress and also in its stretching of the heart. And in doing so, you can get arrhythmias, all kinds of arrhythmias. This is very important to understand that heart failure is a progressive disease. Come what may, it progresses with poor outcomes. And you can see from this graph here in Circulation 2012 that the sudden steep is a decompensation where the patient requires hospitalization. So once heart failure develops, you see the patient has recurrent attacks of acute heart failure which require hospitalization and finally increase in mortality. Here the LIFE study and the RENAL study have shown that the cumulative event rate increase in patients with heart failure compared to those without heart failure. And the treatment, as we know, just one or two slides more, because we have 4 pillars of dysfunction in the mechanisms of pathophysiology of heart failure. We have now 4 pillars. This is a guideline treatment for reduced ejection fraction. So you have beta blocker therapy, you have MRA, you have ARNI, and you have SGLT2 inhibitors. This is the foundation therapy to reduce mortality in heart failure due to reduced ejection fraction. And here you can see that if all these 4 drugs are given, and now they say that once the patient develops heart failure, you have to give all 4 at the same time, maybe in lesser doses, but you have to give all 4, because this giving all 4, you can see from this graph, giving 1 can decrease to a slight extent, giving 2 drugs still less, giving 3 lesser, and if you give all 4, the mortality decreases to a great fold. And here you can see the guideline-directed medical treatment, which is now the update in heart failure. Guideline-directed medical treatment has shown in this that's on discharge of the patient from the hospital. If they are admitted for heart failure, you have to give the guideline-directed medical treatment at discharge itself, not wait for the follow-up to happen, because the mortality increases if this guideline-directed medical treatment is not given. And here you can see 76% did not even receive GDMT, and only 24% received. And you see those who have received the guideline-directed medical therapy did well compared to those who didn't. And these are the final words, my last slide. There is a strong bidirectional association between diabetes and heart failure. Heart failure is the most important, most preventable and treatable cardiovascular complication of type 2 diabetes. A number of pathophysiological mechanisms have been implicated: hypertension, CAD, CKD, and immune dysregulation. And one word about women. Women have heart failure more frequently and earlier than the men, and they have a preserved ejection fraction compared to the men who have a reduced ejection fraction. You have to use the anti-diabetic drugs efficiently. You make use of GLP-RAs and also SGLT2, and also the guideline-directed medical therapy if for the proper management of heart failure. Thank you very much.
Thank you so much, Benny ma'am, for bringing all this to the forefront, the importance of why diabetes and heart failure are linked. And we've always been talking about heart failure as the hidden elephant in the room. We're all very well aware. And the way heart failure happens in women is very different from that in men. So like you said, men get more of a HFrEF compared to women who get more of a HFpEF. So this is something which is very, very important when it comes to the management strategies. So I'll request you to stay back for the discussion after this last session. We now have Dr. Mary D. Cruz, who is going to talk on the lipid guidelines, because whenever we talk of managing cardiovascular disease, one very, very important aspect besides managing diabetes and hypertension is managing the cholesterol levels. So statin, when, for whom, how. So before we start, just a quick introduction. We all know her, a very senior physician and diabetologist, past president, Diabetes Research and Welfare Association, and a vice president of DAY, Diabetes Awareness and You, ex-president API West Bengal chapter. So thank you, ma'am, for joining us, and the stage is all yours.
Thank you so much, Dr. Shalini. Is my screen visible? I'm sharing.
Yes, ma'am.
Okay. So, yes, there is a lot of controversy, and recently guidelines have changed. So Indians particularly have a totally different lipid profile picture. And it was first in 1856 that Rudolf Virchow suggested that blood lipids not only accumulate in arterial wall, but they are probably the cause of major cardiac events. And in 1977, the Framingham study showed that elevated low-density lipoprotein cholesterols and, of course, reduced high-density lipoprotein cholesterol levels independently predict the risk for developing atherosclerosis. And as we know, most of our patients come to us and ask us whether we've got a good cholesterol or high cholesterol, and how do we manage it with our eating habits. So in 2001, the ATP3 guidelines focused mainly on the recognized significant coronary heart disease risk in persons with multiple risk factors, of which the low-density lipoprotein cholesterol less than 100 was identified as optimal then, and LDLC was considered the primary target of therapy with non-HDLC levels targeted at less than 130. So what has happened over the last few years? A new cycle of guideline updates is underway for hyperlipidemia, prompted by advances in the last 5 years, which includes a greater emphasis on early detection and diagnosis of disease and the introduction of lipid profiles, the new biomarkers or updated information, advances in technology, the expiries of patent protection for most statins, and now ezetimibe leading the reduction in acquisition costs. So novel therapies are now also available, PCSK9 and bempedoic acid, which is now available in addition to statins, but then statins retain their space. So peculiar lipid patterns in Indians, already mentioned by some of the previous speakers. South Asians not only have a higher risk of premature coronary artery disease, but also the disease is more malignant. And in India, it has almost doubled in the past 10 years. In fact, 50% of the people dying of coronary artery disease in India are below the age of 50 years. So fatality rates amongst individuals of low-income countries, 96% of South Asia, of whom 83% were from India, was higher than in high-income countries. The earlier age of onset of acute myocardial infarction in South Asians has been attributed to an increased prevalence of cardiovascular risk factors like sedentary lifestyle, abdominal obesity, diabetes, and increased ApoB and ApoA1 ratio at a young age, besides hypertension and psychosocial factors. So looking at the increased sedentary activities like watching television, consumption of calorie-dense foods, 90% of population attributable risk for coronary artery disease can be explained by 9 risk factors, which include sedentary lifestyle, dyslipidemia, and India is in the middle of an epidemic. So there are various guidelines, and I was going through the Lipid Association of India, which has also sent out a video today morning, which most of you would have received. And the population and the factors that are necessary to consider So look at adults with ASCVD and a fasting triglyceride of more than 150 or a non-fasting triglyceride of more than 175 or triglyceride levels less than 500 but more than 150. We also need to look at adults with diabetes who are aged more than 40, no SCVD and fasting TGs more than 150, or again, non-fasting TGs of more than 175 or below 100. So here I'm talking about triglyceride levels because they continue to confuse us, and which and when should we start? Would statins be enough, or do we need to add other agents, or ezetimibe is enough, or do we need to go in for fibrates? So factors to consider are to evaluate and manage secondary causes. We know that poor control of diabetes invariably leads to higher triglyceride levels. Implement guideline-directed statin therapy and optimize statin adherence, which of course is poor in our patients. We also need to treat persistent fasting hypertriglyceridemia, and the optional interventions are necessarily to refer to a registered dietitian or a nutritionist, and addition of triglyceride risk-based pharmacological agents. So adults with ASCVD and fasting triglycerides, which are more than 150, or non-fasting triglycerides more than 175, and triglycerides less than 500 are actually at high risk. And we now have guidelines. We need to rule out secondary causes. We have to optimize diet and lifestyle, optimize glycemic control, maximize statin therapy. In this case, if we have persistent levels of 150 to 500, and if the LDLC is less than 70, again, we rule out the secondary causes. If the fasting hypertriglyceridemia is 150 to 500, and the LDLC is 70 to 99, we need to have a shared decision along with patient preference and give him a combined triglyceride LDLC risk-based approach. Again, if the LDLC is more than 100 and the triglycerides are 150 to 500, we need to maximize statin therapy and optimize adherence. So this, of course, looked at an LDLC. The ATP3 looked at 5 major clinical outcome trials, and the CHD risk equivalent was to adopt an optimal goal of LDLC less than 70 in very high-risk patients, an LDLC of less than 70 in very high risk or for secondary prevention. And this is what I was talking about, the Lipid Association of India, which has the objective of reducing heart attacks in India and raising awareness. We talked of the 9 modifiable risk factors that account for 90%, and we know it's lipids, the increased apolipo. Just a minute, sorry. So we looked at these smoking, hypertension, diabetes, psychosocial, abdominal obesity, reduced intake of fruits and vegetables, exercise, and alcohol. Looking at them, alcohol guidelines, I'm going from below upwards, alcohol guidelines are now recommendations for taking 2 pegs in men, and that should not be in excess of 45 ml, whereas for women, it is reduced to 1 peg. And again, very specifically, if you have ASCVD or you have a high risk, you have not started alcohol, then please do not start. Exercise, again, physical inactivity is one of the major causes, and recommendations for exercise are there for the by the LAI, as well as optimal intake of fruits and vegetables, which Dr. Lily focused on. Smoking is a total no-no, and it is known to be a significant risk factor. Good control of glycemia as well as hypertension is included in these 9 modifiable risk factors. So this was the Interheart study, which showed us control of these factors. As you can see on the right, the lipids here at the end are one of the most important causes. So what we should know that it is not uncommon to observe fatty streaks even from the age of 2 years. And as Dr. Lily rightly said, we need to start early. The first manifestation of coronary artery disease may be just sudden death. And in India, coronary artery disease occurs frequently at a very young age with a high mortality. Moving on. to the lipid profile, where we are looking at the death rate in India has increased by 41%. Lipid screening now. Coming to lipid screening, we are now recommending not only fasting at one time, but also a non-fasting lipid profile, which is now preferred and which also gives us a better idea of the triglyceride levels, particularly after a meal. Patients with heart disease at a young age, or men at 45 years and 55 years for women, or high cholesterol, should screen their children's lipid profile as early as age 2. One of the recommendations was that risk factors to be assessed in men at 45 and women at 55, but most of us have experience of younger women succumbing to coronary artery disease. So probably we need to pull in our data and check whether women at a younger age are also susceptible because of their higher levels of various lipid profiles. So in any level of LDL cholesterol, a reduction in lowering low-density lipoprotein should be 5-year decreases the incidence of heart attack by 22%, 12-year decreases the incidence of heart attack by 32%, and 52 years decreases the incidence of heart attacks by 53%. So the new guidelines, we will go forward to seeing them now. So looking at the, I will move on to the next slide because I think there is a problem. So Lipid Association of India has recommended that on the first visit of any person that we are doing a lipid profile, we need a fasting lipid profile. And on the second visit, the same person should also have a non-fasting lipid profile. On the first visit, if you have a non-fasting lipid profile, then on the second visit, you do ask for a fasting lipid profile. So both fasting and non-fasting lipid profiles are now recommended. And we could do it either way. If the person comes for the first time, send them in for a fasting lipid profile, because most of them are attuned to the idea that they should be having a fasting lipid profile. And then we do non-fasting. Just to share with you, I had a group of about 50 students in a college, and they had the same breakfast. And we happened to do a non-fasting lipid profile, and all of them, barring one student, had triglyceride levels varying from 170 to one particular student who had 450. And their ages were all less than 40. These were students of theology, which I had gone to check. So probably the new guidelines are more relevant in our context. And we have the new treatment goals and statin initiation thresholds based on the risk categories. So the risk categories are extreme risk group, of which category A is those patients who have coronary artery disease with more than one feature of the high risk group. And what are the high risk markers? They are age more than 45 in men and age more than 55 in women, a family history of premature coronary artery disease, current cigarette smoking or tobacco use, and a high blood pressure with a low HDL cholesterol. So you have an extreme risk with these features, and you also have a category B of extreme risk, which is coronary artery disease with more than one feature of very high risk that I mentioned, despite LDL-C less than 50 or a polyvascular disease. And in such patients, we are looking at treatment goals of optional goal, which should be less than 30 of LDL-C cholesterol or less than 50. So we're looking at category A and category B. So category B goes into less than 30 and category A goes into less than 50. We also have treatment goals of non-HDL. And the treatment goal, which was earlier 130, is now less than 80. And the optional goal is less than 60 for the extreme risk category. Then we have a very high risk. These are patients who have pre-existing ASCVD, diabetes with more than 2 other major ASCVD risk factors, or familial homozygous hypercholesterolemia. So very high risk group. So these again need to maintain LDL cholesterol at less than 50, non-HDL less than 80, and consider drug therapy if the levels persist above 50 LDL-C and more than 80 non-HDL cholesterol. Then you have the high risk group, which is where most of our patients come under. You have more than 3 major ASCVD risk factors, which could be age, 45 in men and 55 in women, family history of premature ASCVD, current use of cigarette or tobacco, and high blood pressure. These are the very high risk groups. Again, the targets remain LDL-C, as you can see, 50, 80 of non-HDL-C. Moderate risk group. Moderate risk group patients are those who have 2 major ASCVD risk factors, low risk group with more than 1 moderate risk non-conventional risk factor, and a lifetime CVD risk, which is more than 30%. So other high-risk factors are patients with diabetes with 1 or more ASCVD risk factors, CKD stage 3B or 4, extreme of single risk factors, coronary calcium score of more than 300, non-stenotic carotid plaques, and lipoprotein A more than 150. So now there are multiple guidelines to help us. And these newer goals, I think, target the younger population. And so looking at statin therapy as the therapy for lowering and then going on to moderate levels, 10, 20, 40, and 80 at drug therapy, which is for high-risk patients. Over and above that, if you're looking at lowering triglycerides, we know that 50% of the triglycerides can be lowered by going on to optimal doses of statins. If not, then we could add fibrates too. But again, we cannot add both the statins and fibrates. The complications of muscle pain and other such side effects are more common in our Indian patients, and we need to address those. Another factor addressed by the Lipid Association is the highly sensitive C-reactive protein. And the recommendations are that we can use it as an adjunct to further risk stratify select individuals. And new clinical trials now show that lowering the levels of HSCRP also lowers CVD events. However, at least 2 readings, 2 to 3 weeks apart, must be obtained. And if the second reading is also more than 2, equal to or more than 2, then it can be used for risk stratification.
What can I do for you? I'm in the midst of a Zoom call, actually.
So HSCRP may be used now as a marker for further risk stratification in intermediate risk individuals. And in the post-acute coronary syndrome settings, it is actually a predictor for future cardiac events and should be done at least 4 weeks after the coronary syndrome.
You have my phone number on the.
These are the lifestyle measures, and they are stressed so heavily in the Lipid Association of India guidelines. Having said that, the dietary changes, the saturated fats should be less than 7%. There are guidelines on taking ghee and butter in Indian context because it's a regular food. We have physical activity, and again, dietary changes. They have also recommended going in for intermittent fasting and to change the diets to eat more. Physical activity, again, there are recommendations of levels of activity for different patient groups. Alcohol, I already spoke on. Tobacco is a no. And if you are smoking, recommended to stop smoking immediately. Stress management, a huge factor in the young Indian patients who are suffering from coronary artery disease and actually have sudden death, and which is a failure on our part. Adequate sleep also has been mentioned as one of the factors. So having said that, we have got a number of treatment guidelines which now tell us how to focus on our patients. Treatment with statins is recommended for treatment of dyslipidemias in older people. We are looking at treatment with statins for older people with ASCVD in the same way as for younger patients. No differences. Treatment with statins is recommended for primary prevention according to the level of risk in older persons aged less than 75. It is also recommended that statin is started at a lower dose if there is significant renal impairment or a potential for drug interactions, and then gradually up-titrated to achieve LDL-C levels of less than 50. Management of patients with acute coronary syndrome in all patients without any contraindication of intolerance, it is recommended that high-dose statin therapy is initiated or continued as early as possible, regardless of initial LDL-C values. So the initial LDL-C value is not important if the patient has got ACS and no definite history of intolerance. If the LDL-C goal is not achieved in 4 to 6 weeks with maximally tolerated statin dose, then a combination with ezetimibe is now recommended. And if the LDL-C goal is not achieved after 4 to 6 weeks, despite maximally tolerated statin therapy and ezetimibe, adding a PCSK9 inhibitor is recommended. Lipid-lowering therapy for prevention of ASCVD events in patients with prior ischemic stroke or TIA who are at a very high risk of ASCVD, particularly recurrent ischemic stroke. So it is recommended that they receive intensive LDL lowering therapy. Treatment of dyslipidemias in chronic heart failure or valvular heart disease. Initiation of lipid therapy is not recommended in patients with heart failure in the absence of other indications for their use. Initiation of lipid-lowering treatment is not recommended in patients with aortic valvular stenosis without CAD to slow progression of aortic valve stenosis in the absence of other indications for their use. So with that, I'd like to end saying that even though we have all these guidelines and having gone through the LEI right through, there were no specific guidelines of how much and what should be given to women. In fact, it is now being recommended to look at women above the age of 55 years. As endocrinologists and practicing diabetologists, we probably need to look into this more closely. Also, patients who are started on statin therapy, it is recommended that you recheck levels after 4 to 6 weeks and do it. Unlike earlier when we were checking at the end of 3 months or 6 months. And of course, all these treatments need to start after having given them a 3-month of lifestyle measure changes, which should include no alcohol, optimal exercise levels, no smoking, managing the stress and adequate sleep, along with all the recommendations of diet that Dr. Lily mentioned. Thank you.
Thank you so much, Mary ma'am, for that wonderful session. We'll now have our panel discussion, and I'm very happy and proud to welcome Dr. Brij Makkar, President-elect RSSDI, and Dr. Sanjay Agarwal, our secretary, our very, very dynamic RSSDI secretary, to join us for the panel discussion. Dr. Vasant Kumar and Dr. Banshi had to leave because they had another meeting scheduled. So let's start with the men who've been waiting patiently and listening to all our discussions. Happy to have Anjali also join us now. Welcome, Anjali, Dr. Anjali Bhatt. She's also a very active member of our Women and Diabetes Task Force. Hello. So to start with, this is a question to both the men who've joined in, because you are the key policy decision makers. We've always been talking about how men and women are equal, similar, but yet very, very different.
Shalini, bring on gender bias.
Yes. So I'm just talking about that. So we always, last few years we need gender specific guidelines.
Just give me a minute. I would say hi to everyone because, and also say bye because I have to rush to airport to pick up my daughter. I didn't know this meeting is going to go so long. So I was joined listening to the session. Sessions were very good. And I think Sanjay will take care of rest of the job.
So all the men have deserted me.
Yes.
Yeah.
Yes.
Sorry, but I can't help. Actually, I have to.
Cliche. I think that's
the
cliche.
women power, sir.
Huh?
That's the women power.
Yes.
I should exit also.
Thank you. Bye-bye.
Thank you, sir. Thank you, sir. So, Dr. Sanjay, so the question comes to you. Do you think it is time that we actually understand the differences, respect those differences, get sensitized to those differences. So do you think it's time that we start focusing on gender-specific guidelines?
I think you're right in that sense, Shalini, because we do realize that there are unique challenges that are there with, women, and particularly in the area of diabetes. So I don't think I don't think that we should have very gender-specific separate guidelines for them, but I think we should have certainly a section in the main guideline talking about what is unique to women when it comes to managing patients, specifically where diabetes and non-communicable diseases are concerned, because there are unique challenges that each one of them face. So rather than focus on the fact that do we need a separate guideline for them, I would say that you need definitely a separate section in the guideline which talks about unique challenges related to women. I think that is going to be more forthcoming. And I think in the current guidelines, we have sort of, incorporated a section on women and diabetes. And I think you're part of that section, if I'm not mistaken. So that probably becomes more sort of an inclusiveness to have that, because obviously when you have the main guideline, all the sections are part of that main guideline. So you want to see that everybody is represented, right from child to the adult to women, and every section of them get a place which talks about unique things to them.
Absolutely. So I think it's a very welcome step that we at RSSDI have actually taken notice and given due importance and due attention to all these differences. And that is why this is the first time that we have a diabetes and women task force. So that again is a huge step, and I'm sure with the current leadership and the future leadership, I'm sure we have a lot more in store when it comes to improving the health and the quality of life for women with diabetes. So here I'd like to bring in Dr. Usha, ma'am. Is it only the biological differences, or is it the social determinants also that influence a woman's predisposition when it comes to heart disease?
I think it's both of them. We used to say about diabetes, right, that genes load the cannon, environment pulls the trigger. We used to say that it's something like that. So, for example, I spoke about the unique life cycle of women, and then I also spoke about physiologic, pathologic differences. So all that actually, sets the background. And then depending upon, women's, that particular woman's health literacy, education level, her lived in, her environment she lives in, access to healthcare, the healthcare system she belongs to, health disparities, inequities, all of that then adds up. And then, for example, if there is a woman, let's say in Chennai, who is well informed, and then she doesn't feel well and thinks this could be my heart, goes and sees a physician who is able to pick it up, give her the right treatment. So that is one thing. You imagine another woman in a village from far away from Chennai who doesn't know what is going on, goes to a doctor who also is not able to put his finger or her finger on that, and then sends her to the emergency room where they miss it, and then she doesn't have access. So I think it's a combination of both, and some of these factors we may be able to help modify, but I definitely think health literacy, health education, and this year's theme for World Diabetes Day is education. So I think that makes a big difference.
Absolutely. I think it's the fact that we need to make our women aware of their risks, the importance of looking after their health, not only once the disease sets in, but to actually prevent the disease. And even if you pick it up early, ways of probably taking measures to, prevent that from taking a toll on their quality of life as well. So this brings me to Dr. Lily, ma'am. When it comes to heart disease in women, do you think the symptoms are also different when it comes to the women with diabetes compared to women who do not have diabetes, and the men as well?
Yes. Even though the heart disease is the same, the symptoms may differ in women with diabetes and heart disease. The women with diabetes, they may not have any symptoms. Secondly, they may just complain of weakness, fatigue, and not attribute that weakness and fatigue to the heart disease. So, and then they might collapse one day in the kitchen or, in the house when there is no one around. So that could be that. And then third difference is that, the symptoms may not be classical in women, like chest pain in the substernal area. It may be pain or uneasiness, as Dr. Usha showed in her one of her slides, that they may just complain of head, heaviness in head, or shoulder pain, or back pain, or symptoms of upper abdominal pain, like more like acidity. Than this can happen in men as well, but women more so. So these are some of the differences that we see in women, and also the women do not take cognizance of these symptoms. That's another reason. They are more busy with their looking after the rest of the family members, and they forget that they can also be sick.
Absolutely, ma'am. So
Yeah.
I think it's very important for us to understand that sometimes the symptoms will not be the overt symptoms. Half of the times the aches and pains, we just kind of push them under the carpet, saying it's more of a psychological ache and pain rather than something which could be an organic disease which needs to be taken care of. So I think that is a very, very important point that you brought forward. Taking this forward, Benny, ma'am, we always talk about the traditional risk factors for CVD in women. Do you think now we again have an emergence of various non-traditional risk factors also when it comes to CVD in women, especially the ones with diabetes?
Yes, actually, the traditional risk factors, which are common in men and women, but they are more aggressive in women. That's the driving point I want to make. And also, there are risk factors like smoking, which is also increasing in women. We always thought of it as only in men. And sedentary lifestyle, for example, work from home, etc., which is the next, smoking. These are traditional risk factors. If they have diabetes and dyslipidemia, the dyslipidemia is more heterogenic in women. But then there are other non-traditional risk factors like PCOS, like, complications of pregnancy, gestational diabetes, hypertensive disorders of pregnancy, also delivering a small for gestational age baby. That also predisposes them to cardiovascular disease in the future. And now you have, novel risk factors like autoimmune disease, and cancer is a risk factor, and also depression. And we have heard of that Takotsubo heart disease, which is a broken heart syndrome, where due to extreme acute stress, the women go into cardiomyopathy. So, I think depression and stress has to be highlighted and taken care of besides the traditional risk factors.
Absolutely, absolutely. Dr. Anjali, I would like to bring you in here. Dr. Benny mentioned PCOS as something which is very, very important, because we know women with PCOS have their own individual increased cardiometabolic, cardiovascular risk. And when these women get pregnant, gestational diabetes is again something which is which is considered to be very strongly associated with PCOS. So how do both these conditions individually as well as together predispose to an increased CVD risk when it comes to women?
Right. So in a couple of lines, I'll tell you about the recent evidence that I read about it, where this was a meta-analysis which showed that women with gestational diabetes mellitus have a double risk of cardiovascular disease. And even I was, though not surprised, but it was important to see that these are some women who do not even develop type 2 diabetes after the pregnancy before they develop the cardiovascular risk. So I think there is a very strong continuum from having a higher risk metabolic profile, including the factors traditional and non-traditional that Dr. Benny ma'am mentioned, which can start at the birth with low low weight for the gestation, or even before that, some epigenetic changes during the intra-utero time. This is a profile that finally leads to a cardiovascular event and increasing the mortality and morbidity. PCOS, gestational diabetes mellitus, development of hyperglycemia, and then development of cardiovascular risk these are the stations on the way of a high risk to developing the disease. And I think if we are aware of these continuing points, rather than trying to wait for type 2 diabetes to develop, we can pick them up at an earlier stage And the windows of opportunities are gestational diabetes mellitus. Windows of opportunities is PCOS. Windows of opportunity is hyperandrogenism. Window of opportunity is a young girl with obesity, young girl with dyslipidemia. And earlier we pick them up, we are able to change the outcome in terms of either that generation's health as well as the previous generation's health, because we're talking about girls who are probably going to get mothers who will also carry on the risk to the next generation. So I think there is a continuum of this risk. Rather than trying to wait for the outcome to happen, I think if we take these as a windows of opportunity and start acting, that will be what we can expect to change the outcome.
Absolutely. I think these are problems that are very, very unique to a woman, predisposing her to an increased CVD risk. And that is why it's important that we take cognizance of these well in time. They always say a stitch in time saves 9. So I think this is something that we need to sensitize ourselves and take steps so that we can probably make an attempt to nip it in the bud before it grows. With that, a question to Dr. Mary, ma'am. You talked about the lipid guidelines. So does it translate into, do all women actually need statins? And if yes, at what age do you recommend statin? And what is that specific factor where a woman with diabetes should be on a statin?
So women and men, there was no distinction in the guidelines. And they said that there are risk factors, which are major ASCVD risk factors. And among them, it's hypertension, smoking, and also low HDLC. And again, age. So age of women was specified as more than 45. I mean, women more than 55. So if you're going by guidelines, that remains. And yet it says that if you have a strong family history of women who have died at a younger age, which was specified as less than 65. So if that kind of a history emerges, along with the other risk factors, which is diabetes with one other major risk factor, which I just specified, if the CKD is present, or if there is an extremes of one single risk factor, and then coronary calcium score of more than 300, I think all these put together actually would put women recommendations to be started even earlier. And,
absolutely.
I mean, absolutely. The same as men, probably. Same as men.
So since we are short of time, just two quick questions. One to Dr. Lily, and then we'll have Dr. Sanjay's views. Dr. Lily, ma'am, the question for you is, we've seen how CVD is much more, women with diabetes are more predisposed to CVD. So what do you suggest? What kind of CV risk assessment do we need to do for these women with diabetes? Because they will not come to you with CVD presentation. So how do we assess the CV risk? When do we start assessing, and what should be done? Ma'am, you are muted.
As I said in my the last slide of my talk, I think it is mandatory for every doctor, man or a woman doctor, to have a CV risk assessment clinic in their own clinics at least once a year, when at the time of diagnosis or first visit of that woman or a man, to be assessed with the risk assessment score. And of course, first it starts with the biometrics. It starts with waist measurement, height and weight, and BMI. And then it starts with the glycemic control. And then the first visit, only lipid profile can be done. And as Mary clearly said, the next visit should be, if the lipid profile is abnormal, after putting them on the treatment, maybe after 6 weeks or so, a fasting lipid profile is to be advised. And then, of course, the other risk factors like uric acid and maybe ECG, whether it is useful or not, it should be done at least once in the risk assessment. And then family history of cardiovascular disease, family history of history of gestational diabetes must be recorded, and then history of large for birth weight has to be recorded for that mother. And then the diet of the woman has to be looked into. whether the woman is eating a healthy diet or not, and if the woman is weighing more than her height, the weight reduction has to be advised with a proper and healthy and right choice of diet.
Absolutely, absolutely. Before we close, and I put on my question to Dr. Sanjay Agrawal on policy matters. Dr. Anjali, mental health, does that also have an impact on a woman's cardiovascular risk?
Absolutely. And I think this is something that has always been put into a back seat when we are dealing with women coming, because we started this panel discussion, you started with such an important question that all this risk is it pathological, physiological, or it is environmental? So it's very difficult to separate these things, these two things. I'm sure all of us are aware that now mind-body medicine has coming up in a huge way, that whether the physiological problems start because of a psychological problem or it is on the other side, becomes very difficult to separate. And we will have to address these two issues simultaneously if we have to improve the health. And in India, there is enough evidence to suggest that the mental health issues are more common in women than in men, probably because women have to deal with much more than at all fronts, whether it is professional or personal, than men. And I think you have raised a very important question, and this needs to be addressed in its fullest form.
Absolutely. So, since we need to close well in time, Dr. Sanjay, a question to you as somebody who sits at the helm of affairs. Setting up the task force for women with diabetes was a very welcome step that RSSDI took to actually give importance to the issue of improving the life of women with diabetes. So your vision for the future, do you think organizations can play a very pivotal role when it comes to creating awareness, amongst the healthcare providers on the different needs that women have when it comes to their heart health, their mental health, their physical health, their social health, and B, amongst the common public? So do you think organizations like RSSDI, we have an outreach both to the public and to the healthcare practitioners? So your vision for the future when it comes to the arena of women's health, women and diabetes?
I think I like this question very much. And let me just break it down to what is the hard reality today. I mean, we have a major challenge when it comes to access to healthcare where women are concerned. Let's start with that. I mean, although we stay in urban areas, but you go down to the rural areas, the major challenge is access to healthcare and good healthcare. And very often when something has to be compromised, it's compromised with the women more than the male genders. And for that matter, even for the children, for that matter. So I think the women always take the last step, whether it's eating or whether it is getting access to health or economics or whatever it may be. So I think the first thing that we really need to provide is good access to healthcare, irrespective of the fact where they may be. And I think as part of the RSSD initiative and part of one of the tasks which we entrusted the Women's Task Force was that can we sort of go and have every place in the country represented to provide good access to healthcare, whether it is hospitals, individual clinics, or in terms of public forum where people are made to realize that women's health is prime driver for good health of the country itself. I mean, I would put it in a more broader sense of the word. Second thing is, I think lifestyle changes are extremely important, and I think it starts right from the fact that when women get pregnant and thereafter they lose control of their own health and they get involved in the children, their husbands, their families, they tend to neglect themselves in a very major way. They tend to put on a lot of weight. And we know that today obesity is a driver for all non-communicable diseases. And we don't sensitize women on the importance of weight. And that's something that you see that post-pregnancy, whatever weight they tend to put on, that sticks with them. And you see their before and after pictures and you suddenly realize that there's been a major sea of change that's happened. And they tend to sort of get involved in thinking that, okay, this is a life and this is how it should be. Now, that is something that we need to change that mindset, because we shouldn't be just looking at a very focused area of diabetes. I think it should be more broader in the sense that non-communicable diseases, mental health, happiness quotient, all these are extremely important when it comes to women. And unless we really drive that point, it's going to be very difficult. Third thing is, of course, that we need to start our screening procedures much earlier. And I think all of you have mentioned that part of it. Because gone are the days when we thought that premenopausal women are not exposed to cardiovascular risk. I think they are now as much at risk for anybody else. And we have enough data to show that people who are destined to develop prediabetes started even before the onset of prediabetes itself. You look at various studies, the Nurses' Health study, the Norfolk-Suffolk study, and all these, you find that the risk conundrum starts even before the diagnosis of prediabetes. So what you need to look at is the complete cluster of risk a person carries for development of any non-communicable disease. So while Lily and others have talked about, how would we screen? I think we need to look at more how many sort of factors which predisposes a person for non-communicable disease a person has: obesity, smoking, alcohol, dyslipidemia, family histories, pregnancy outcomes, all these things, they put together would probably, you need to start identifying all these women and have conversations with them when they come to you for any other purpose, that what is the risk profile they carry. And you need to at least sensitize them to the fact that, they need to check their, profiles periodically, whether it's blood pressures, whether it's just simple, point of care testing for blood sugars, or, just simple checking up their BMIs, so that they're aware about the fact that health is important and they need to look at a long-term perspective for the health part of it. And if affordability is a major question when it comes to routine testing, and there's been a lot of pluses and minuses where people do argue the fact that do we need to do routine screening for everybody, or it should be selective screening. Now, that's a point of debate that, we shouldn't sort of get into. But obviously, should be no question about the fact that women of high risk should be screened. And that is a mandate that we should have in all of us. So if you have, and I don't know how many of us actually look at ASCVD risk scores, and you've got enough, Q risk scores and so many others risk scores, at least we should sort of, if nothing else, that Q risk score at least gives them an indication that figure is abnormal and they need to correct that figure. But it kind of covers up most of and does have a representation of the Indian population. Other than the Framingham risk score does not have any Indian population, but the Q risk score did have Indian population. Then we have our own Indian risk scores also. And lastly, of course, unless we all talk and, sensitize the society towards women, we're not going to make a big dent. We are a small group of people. And, in a 1.3 billion population, we need to make more awareness through, collateral involvement of other organizations. And what you started out asking me, that how organizations should function, I think we may have taken the lead through RSSDI, but I think it should be a voice that every organization should have, because otherwise we are going to reach only a minuscule population and we're not going to reach the large subset of people that need to be sensitized. While, urban population women would have access to social media, TV, print media and television media, the women back, in the rural areas would have very little access to any of these things. And I think it's important that rather than, if you ask me where I would put the money in, I would say go to the rural areas, talukas, districts, and that's where, there has to be more conversations like this happening, because it's good to have such meetings. I would suggest go back and see in the analysis what were the section of doctors who joined to hear this meeting out. And if you had a representation in this meeting in your audience who are from the distinct areas, I think this meeting was a big success for me.
Absolutely. I think this is where I think beginnings have been made. We've tried to reach out to as many people as we can, and the efforts will definitely continue, both when it comes to the healthcare practitioners as well as the common public. And we just had an episode on Diabetes Bites where we had a discussion on the women and cardiovascular health. So I think the beginnings have been made, and with the organizations very much willing to carry the torch forward, I'm sure we do have a huge, great vision, and we're out there. to spread. Dr. Lily wants to say something.
Yeah, I just wanted to request you, Shalini, to announce the small.
Yes. Yes, that's exactly, yeah. So yes, so for all the delegates who are logged in, we're very happy to announce that Emcure has been partnering with us with the RSSDI and the Women and Diabetes Task Force on various initiatives that we want to do in improving women's health. And we've been doing a lot of things as part of the World Heart Day celebrations and improving the cardiovascular profile of our women. Emcure has agreed to partner with the RSSDI, and we will be sending out coupons, 20 coupons each, where for the women patients that we see in our OPDs, where we will be carrying out basic tests like a lipid profile, an HbA1c, a simple serum creatinine, and a random sugar at a very, very nominal price at a lab where you can just call them and get your sample collection done at a very, very nominal price. And then we will also be sending a link to all the practitioners, all our RSSDI members, wherein you can go back to your records, look at the lipid profiles of your women, and we'll be sending you a link for an atherosclerotic cardiovascular disease risk engine. So all you need to do is put in that data, enter the lipid profile, age of your patient for your women patients with type 2 diabetes, and assess their cardiovascular disease risk, because this is something we have to get into a habit. I remember a long time back, when we had to talk about the kidney, everybody used to look at serum creatinine and say you have CKD. Now we know it is the GFR. So I think we've all gotten into the habit of calculating a GFR every time we see a serum creatinine report from our patients. And so that is a huge change that has happened, at least in our practices. So now I think it's time we take another step forward and start assessing the atherosclerotic cardiovascular disease risk of all our patients, and especially women sitting in front of us and partnering with us. Emcure has kindly agreed to associate with RSSDI and help us fund this project, which we will be launching as a nationwide project very soon. You will be hearing from us very soon on that. So with that, I think all good things come to an end. It's time to close. And Dr. Mani, just a quick comment.
I just want to have the last word. I'm so happy Dr. Sanjay Agarwal is here. Yes. And he's the only male now among the women.
Absolutely.
And we should really congratulate him, because I think during his tenure, the entire RSSD team has really catapulted all these task forces to the fore. And I'm sure that he, being the secretary of the RSSDI, he will do much, much more. And he has also outlaid all the plans. We are very happy about it, Dr. Sanjay, and we really wish you all the best. We are there with you in whichever project you and both of us, all of us undertake. So all the best.
I'm very humbled with this, appreciation, but I don't think I could have done anything without the support of everybody, all of you, and like-minded people in the body. I think it's very nice to see the body grow, and we have now made strides in so many areas, but I think it's been a collective effort of everybody. So I think thank you. I should thank all of you for being part of this journey.
I would, in a special way, thank Emcure today.
Absolutely.
For having partnered with us for this particular CME. Particularly, I want to mention two names, and that is Satvika and Chandramohan. And wish Chandramohan good health, because I am told that he is not well and is admitted in Ruby Hall. Thank you very much, Satvika. And thank you, Chandramohan, if you are listening to us. It was a great cooperation and coordination from both of you. Thank you so much.
So it's time for the vote of thanks. Many, many thanks to everybody who's joined in today, right from our current president, Dr. Vasant Kumar sir, our past president, Dr. Banshi Sabu, our president-elect, Dr. B.M. Makkad, and our most dynamic secretary, Dr. Sanjay Agarwal, whose brainchild, I think all these task forces have been, and I'm sure we have, again, something to look forward to coming out from his magic box. Let's see what else is in store, and we assure you of all our support when it comes to taking the issues of women's health forward. I also want to thank all our faculties, eminent faculties, Dr. Usha Sriram, Dr. Benny Ma'am, Dr. Mary D. Cruz, and my colleagues in the Women and Diabetes Task Force, Dr. Lily and Dr. Anjali, for joining us today. It's been great. And many thanks to our sponsors, our partners, in the Sakhi project, Emcure Pharma, Satvika, in particular, who's been in touch with me all through the year with all the posters, all the inputs that we've been planning, and Chandra Mohan, who has helped us coordinate everything, along with the top leadership of Emcure. And many thanks to our broadcast partners, RX Events, for seamless broadcast of this program. And last but not the least, all the delegates who've been joined in. I'm told we have 200 plus logins. So that speaks for the success of this program and the importance that we need to place when it comes to women with diabetes, women's health in particular in general, and women and CVD when it comes to heart health. So yes, it's time to use a heart for every heart, the theme given to us. And I'm sure this will make a difference because it must have touched a chord in everyone's hearts. So with those closing lines, a very good night. Stay safe. Thank you very much.
Good night.
Thank you.